is Joy Nix, who will be presenting on access issues for CRT via case studies. Joy is an assistive technology professional whose passion for assistive technology is evident in her drive to help people live independently, engage in their communities, and maintain active and safe lifestyles. Joy understands the crucial role mobility devices play in preserving individuals' autonomy, dignity, and choices in how they want to live their lives. Her role as an ATP with New Motion focuses on alternative therapy sites and underserved population, showcases her dedication to ensuring the assistive technology is accessible to those who need it the most. Welcome, Joy.
Thank you. Awesome. So hello, my name is Joy, and I'm your assistive technology professional today. And I want to just start off by explaining my alphabet soup up here, because they're kind of unknown letters for most people. So ATP is the RESNA certification for assistive technology professionals. So that specifically focuses on assistive technology, seating and positioning, and is required to have someone involved with that title if you are processing equipment through insurance. So all providers that you work with will have that credential. CIFT is Certified Inclusive Fitness Trainer. So I was in the world of sports for a while, and that is working specifically with people with disabilities in sports and training. And then the MS is a master's at University of Pittsburgh in rehabilitation technology. So that's kind of the rehab engineering side of things. But the most important thing today is that all of us are here because we have the same job. What do we do for a living? We do our best, okay? And we do our best for our patients and our customers, and we do our best based off of our knowledge, our resources, our time, and our capacity, and the systems that we function within. Okay, so can I get a show of hands for people who think that they are limited sometimes by the systems that exist in the world of rehabilitation? So if there's some kind of thing that limits you, that kind of causes some frustration occasionally, that makes it hard to care for your patients sometimes in certain ways, can I just get a hand if you sometimes experience that? Okay, that looks like pretty much everybody. So today I want to really reiterate that we are doing our best, okay? And you guys are doing great. The fact that you're here is awesome. There are some things that we can share with each other so that we can see what else we can do, okay? But nothing is ever really going to be perfect, and we can't do everything at the same time, okay? We can do anything, but we can't do everything. Today, through the case studies and things, I am going to encourage some interaction with your neighbors to get out of our kind of professional silos that sometimes we're in. If you're talking to your coworkers all the time, I'd encourage you to try to kind of pair up with someone who maybe you don't work with, just to get a different perspective on kind of how their team works. If you want to stand up and look, I'm going to be sitting a little bit to demonstrate some of the case studies. Because of HIPAA, I don't have photos, but I can talk about all the case studies. So if you need to stand up, get closer, move around, do what you got to do to kind of stay engaged, because I think we're going to have a lot of fun here. So here we go. So here are the learning objectives. So the goal is really to know what is required to ensure that a provider can follow up with patients about wheelchair needs. That is related to me working with New Motion and knowing that kind of provider side of things, but also understanding the clinician role, or your role, in helping with equipment orders and what people need to be independent in the community and in their home. And then also know how and when to get new equipment, or when that's needed to kind of get looked at. And then also, who is the team? What are the roles? What are the expectations? Okay, so that's kind of what we're going to try to do today, if we can get through it. So we all have different reasons for being here, or ways that we got into the field that we're in. So I'm going to give you a very brief overview of my background. So back in 2000, I think it was. No, maybe 2005. The movie Murderball came out. So MTV changed my life, guys. It really did. So I don't know if you guys have seen it, but it's about quadriplegic rugby. Okay, and I was in Austin at the time, and that's Mark Zupan, and he is on the quad rugby team in Austin. Okay, so I got introduced to this, and I got just totally fixated on it. I watched it every day for like 3 months. I was just amazed. These folks who most people would be like, a quadriplegic playing rugby? What? Right? It sounds insane. But the way the rules of the game were designed, the way the chairs were designed, and the way the training worked, it harnessed ability in people who most people didn't see that ability. And a lot of the people doing that sport didn't know that they had that ability. And that was life-changing for me of a realization. So when I talk about kind of what I do, I help harness ability, okay, through equipment. Okay, so I studied kinesiology at University of Texas, and I was a rower there, D1 rower, and I continued rowing after college as well. And in 2008, it became a Paralympic sport. So that is when I got pretty excited, because I was like, oh my goodness, I can do murder ball but rowing. Let's do it. So I got really involved in that and started a bunch of programs, ended up traveling the country doing kind of Paralympic education and recruiting, working with specific patients and specific equipment, being involved with some of the design of equipment for para rowing. And through that, I also got to see some really cool chairs it took me a minute to realize that that chair was a custom chair. I didn't really think through that there was a process to get that. I was just like, man, that's a cool chair. Let's get you in the boat, you know? So it just wasn't really there. And then I was like, man, that's cool. So I'm helping people, you know, get fit and do things, but I want to help them in their daily life. I want to harness their abilities so that they can do more basic functions, be more independent. So to do that, I decided to go to grad school. So I went to University of Pittsburgh, and my graduate advisor was Mark Schmeller, and he's awesome. And I studied rehabilitation technology. So that's all types of assistive technology. But I just took his advice. I was like, what should I do with this? He was like, you should go be a provider. And I was like, okay. So now I work for NewMotion, and I work with kind of alternative therapy sites. So if a lot of you are at Toro or in the clinics, you might not kind of know me very well because my colleagues work there primarily because I'm more in the home. So I do a lot of work with home health. I do a lot of work with like primary care doctors, a lot of folks that have maybe less experience dealing with wheelchairs and more rural communities, things like that. So I do a lot of driving. But I really like the opportunity to get in people's homes to help them. So that is what I do. That is what I do. So here we go. So what is complex rehab technology? So does anybody not know that term? Okay, that's fine. So complex rehab technology, so DME is durable medical equipment. Okay, that's like stuff off the shelf. Okay, a lot of insurances, CRT is kind of under those policies for DME, but CRT is complex, meaning it's custom. So when someone is sitting, okay, whatever their position is, however they sit in their functionally neutral position, let's say they sit like this and they can't move from this position, well, now we got to look at their angles. We got to look at their size. We got to look at their width. We got to look at where their pressure is. We got to look at the textures that are touching them there. We have to look at all those things. And that's what gets them sitting safely. And if we can get them sitting safely with something with wheels, now they can do things. Now they can go get a glass of water. Okay? So it's real basic stuff. And we can also get them out of bed where they don't have positioning support. Right? So if they're just in bed, they're going to get those contractures and hopefully they won't become non-reducible, right? So these are the things that we look at, okay? And a lot of you are therapists who do evaluations, so you kind of understand that we kind of evaluate all of these things. So why are we talking about this today? So the main thing is I want to really challenge you to just think through what is your role in the process of seating and mobility. Because the plan of care for that is very different often than the plan of care that is kind of the top priority of maybe what you're working towards. Okay, so when are you thinking about that? When are you getting an ATP involved? How does that work? So right now, I want you to kind of, just to have an anchor for the presentation, I want you to think about a patient that you're working with, okay, or one that you worked with recently that had some physical mobility issues or positioning stuff. So I'm going to give you a minute and just really think about it. Get that anchor. It'll help. Everyone got one? Okay, great. So with that person, we're really focusing on getting them good outcomes, right? Outcomes are good for everybody. Like when we reduce readmittance to hospital, when we increase independence in the community, when we reduce people going into skilled nursing homes, and we just get them more involved in their life, that's great for everything, okay? So that is what we are trying to do. So let's take a look at some case studies. So we all have stories. I'm sure that I would love to geek out with all of you about some of these stories, okay? We have a lot to learn. These are just 5, okay? But we all have a lot more, and I really hope that we can create a dialogue where we talk about them in a way where we're not trying to create like the perfect system, because we got to fight for that. We got to advocate for a good system, but we also really need to push all the boundaries of what we can do within the systems that we're in. Okay, what can we do? What's realistic? What's the bite we can take that makes a dent? Okay, so this first patient, and I'm going to rely on my notes a lot so I don't miss anything. So this patient had hemiplegia post a CVA and was at an inpatient facility. Okay, and you guys know insurance is really shortening the number of days that people get in those facilities. So right after an incident, the plan of care isn't necessarily talking about how they are going to move around their house. We are talking about how do we save their life? How do we prevent another stroke? How do we get them so that they can swallow, right? So the plan of care is kind of oriented more urgently, right? So the therapist did bring me in. She wanted me to come kind of check things out and introduce myself, things like that. The other thing that happens at inpatient is that there's a lot of information getting thrown at that patient, okay? And you guys know they do not absorb everything. So I go and I talk to her, and the therapist is a little nervous to do equipment because she doesn't want because the patient hasn't stabilized yet. We don't know exactly where she's going to be with her mobility long term. And if we do an evaluation right now, it might not be right, okay? It would be a good guess, it would be close. All equipment can be modified, okay? So, and we do check before delivery to see if there's any changes. So there is a little bit of a catch to that we can kind of help with. But I understand they want to wait for the patient to stabilize, okay? And also inpatient, some doctors aren't crazy about doing the paperwork because then they end up having to sign something once the patient's been discharged. Okay, now all that paperwork is based on the one day that the evaluation happens. So they're not signing off on anything of their condition in the future. They're just saying on that day, that was accurate. Okay, so you can kind of encourage folks about that. So anyway, so I was like, okay, so you don't want to do a chair, that's fine. I introduced myself and gave them my card. Could you send me a face sheet? And I will follow up with them in like 3 months and just see where they're at and if they have any needs, okay? And they weren't comfortable doing that, and that's okay, because it wasn't the plan of care, right? So everybody's doing their job. Everyone's doing their best, okay? But they really wanted to encourage the patient to be more physically active. They didn't want her to kind of get lazy by having a wheelchair or something like that. So anyway, so didn't hear from the patient, and I can't contact patients, okay, unless I get a referral. I cannot set up on the corner, because I'm a provider. This is a compliance rule with Medicare. I cannot set up on the corner and say, do you need to know how to get a wheelchair? Does your wheelchair need repairs? I can help you. I am the only person who knows how to do this stuff because there are only like 5 ATPs in the region, right? Well, not ATP, providers, right? Or there are more than 5, but there's very few. And we're the only ones that know all the things about this. And we're the only ones that can't tell anybody. We are only allowed to tell you. We can tell clinicians, Okay, but we can't recruit because it's sales. So I can't recruit. Okay, so if they give me a face sheet, I can follow up. Okay, that gives me access to actually doing that. I gave the patient my card, but she has too much information that she's getting. That's getting lost. Okay, so 6 months later, I get a call from a home health occupational therapist who got called in to work with this patient. And April, you know who I'm talking about. And she now has some contractures, starting to have some skin breakdown, and she is fully dependent on her husband to lift her for all, like they don't even have a wire lift, like to lift her for transfers. And they're trying to get family and friends and hiring help to come in because she can't be alone ever. Okay, so now the stress is on the family. Okay, so we go in, we do an evaluation. She has some funding, so we're able to do the standing feature, which is awesome. And now she's independent. Now she's able to be alone. Now they're not spending money on caregivers, right? Now she can have a relationship with her husband where they're husband and wife again, instead of just caregiver or patient, right? So these are things that we can do, okay? So was it kind of overly trusting the system? I mean, she was on the verge of almost needing to go into a skilled nursing facility, right? And then also the stress on the home relationships, right? So there was just a gap. It was just a 6-month gap. It did get caught. That's great. That's a success story. But she also started having contractures and skin breakdown before we could get things set up, okay? So just something to think about. Okay, so this is kind of the catchphrase that I want to encourage, and the last presenter talked about it as well. It's a team, okay? I know the equipment. Most of you, I think, are kind of therapists. You guys know bodies really well, okay? And the patient knows their life, okay? They know what they need, how they're going to do things, their relationships, their support systems, their finances. And so making a decision without involving them, we just want to make sure we're involving them. Okay, they need to have control over their life. Just because we're giving them a tool doesn't mean that they're going to be stuck in it and that they're not going to do other things. Okay, but if we give them a tool, now they have a choice of how they're doing things and how they're engaging in their life. Okay, if you're not sure if somebody really needs equipment, can they be consistent with their ADLs? Can they do it at any time of the day? Can they do it repetitively? What about on a bad pain day? What about after 3 p.m.? What about on a bad mental health day? What tools will help them be independent during all of those times? Do we need to involve an ATP for the discussion? Okay, I think a lot of times ATPs are seen as salespeople because technically we are medical sales, right? And that's the system that we work in. That's the label. But the ATPs want to help more than anything. So we are a resource as well as a way to get the equipment, if that makes sense. Okay, so next. Okay, so this one was a referral from a long-term care acute center. And I went in, I was called in by the PTA, so the physical therapy assistant, to do a chair for someone in there with pretty late-stage ALS, okay? And so we did that, and while we were there, he was like, well, if you can do a chair for that person, I wonder if you can help this other person. It opened up a door of like, wait a second, you might be able to do something, okay? And so I went in, and he was like, he's kind of belligerent. And I was like, okay. So I went in, and he was. And, but poor guy, man, he has had a very hard time. He's a young guy, 16 years with a spinal cord injury. And he had a custom manual wheelchair and good strength, all the skills, wheelies, he could do everything. He could do the slalom courses and all that. And when I went in there, he was just so upset because nobody was listening to him. He didn't know how to advocate for himself. So I deal a lot of times with people who are frustrated and angry because using equipment isn't always something that is very exciting to most people. But once you explain that it's giving them freedom, that they still have choice, that they have autonomy, and you explain the route of how they can effectively advocate for themselves, they get much calmer, okay? So, because frustration is really built on not knowing how to get help and feeling lost, right? And that is a painful place to be. Okay, so he actually got really involved in his case. So the doctor there really didn't want to do the manual wheelchair. I mean, he was dealing with a pretty major infection. So again, plan of care, save life. Yes, I approve of that being first. Good job. But after that, there was not really much setup for him. So the therapist that was there was willing to do the evaluation, so we did the evaluation. And then he got out and he had to get to like a primary care doctor in order to get the notes from the doctor that say that he needs a chair. Okay, so we did that. It took a little while. He had some major transportation issues because he's using a K1 chair. A K1 is a basic chair. He has a sling. Okay, he has wounds. He didn't even have a Roho cushion. Like, he didn't have any kind of cushion. Like this, I mean, it was just, and severe contractures. He had surgery a couple years earlier, and he didn't have much aftercare. So just to show you kind of what his leg position was like, it was like this. So his legs are in a non-reducible contracture like this. So they can't move. Okay, so you can't correct this. And he had so many wounds and things going on that his seat was like an arrow. You know, like just the pressure was just all in one place, right? And so he just couldn't really be in a chair. But he lives alone. So anyway, so we did all that, and unfortunately we got a denial from insurance, okay? And so I went back to the therapist, and of course now he had to have a doctor's appointment after the LTAC. So we're like 4 months out now, okay? And the therapist isn't working with him anymore. And so she was not willing to do the appeal documentation explaining how he does the ADLs. Okay, and the real reason is she didn't think he was really safe to do transfers by himself, which is true clinically. But what about functionally? Where am I at? Okay, so, pardon me. So I did the appeal, and it got denied because I'm not a clinician. Okay, so I did my best. I did my best within the systems. I thought it would work. And I want to read you the appeal letter, okay, just so you can know. So if you ever deal with this and you're a therapist, if you speak like this in your fun therapy words that I don't know, it will probably get approved. This customer has used a custom manual wheelchair since he was hurt 16 years ago to be independent. It was only recently after surgery and hospitalization with limited aftercare and therapy that resulted in his limited movement and bed-bound situation. It was also at this time that he did not have a custom chair and was left only with the option of using a standard K1 wheelchair that was too wide for him and had no cushion. With severe contractures, a very narrow frame, his body frame, and multiple decubitus ulcers, it has been safer for him to remain in bed than attempt to use his chair. In bed, he has had no postural support at all 24/7, which has allowed his body to contract in any direction. Even in the manual wheelchair, he continues to have no positioning support to help him get into any functional neutral position. Although it might be clinically ideal for him to have assistance with transfers, as noted in the PT evaluation, he does not have assistance from any family or caregiver in his home. His standard chair further worsens his sores and has no lateral stability, making him feel very unsafe trying to get in and out of the device. Due to his leg contractures, he cannot use the foot plate at all, and his legs are left hanging off the front, further worsening his stability by pulling him forward out of the chair. He cannot sit balanced in the chair and then also use his arms to propel himself in his home. If he removes his arms to push the wheels, he loses balance and falls out of the chair. He only gets out of the chair when absolutely necessary. He can only eat canned foods and soups as they need covers so he can carry them from the kitchen to his bedroom, and because he cannot stay in the chair long enough to prepare or cook anything in his kitchen. He does not do laundry, but when his clothes get too dirty to wear, he throws them in a corner and buys new ones online to have shipped to his home, an expense that may be partially why he cannot pay for any home support. He had great wheelchair skills prior to his recent surgeries and was easily able to get up down the 2 steps of his apartment stoop, but now he requires help doing this because of his instability and pain using the standard chair. Most taxi drivers he tries to utilize to get to appointments are not willing to help him up down these stairs. And if he can't be independent getting in and out, he also cannot use public transportation to get anywhere. He is therefore unable to be compliant in going to see doctors, get to wound care, to treat his severe decubitus ulcers or receive any outpatient physical therapy. This is partially what made his situation so severe that he had to be admitted to the LTAC earlier in the year for treatment. He has had severe falls 5 times since being discharged from the LTAC, and the fear of falling keeps him in bed as much as possible. He has also had the chair tip over backwards while trying to push it because he can't keep himself stable in any direction. In the LTAC, we did a trial with a narrow frame ergo seat chair, custom chair with a Rojo cushion. He said that he felt like he was sitting on a cloud with immediate pain relief and that he hadn't felt that stable sitting up since before his recent surgery and injuries. He has been very engaged in this process of requesting authorization for a chair as he expresses that it will be life-changing for him. This chair, as specifically designed for his specific body needs, will allow him to be in the chair throughout the day instead of keeping him in bed where he has no postural support at all. With stability in the anterior, posterior, and lateral positions, and his weight balanced over the axle properly, he can utilize his wheelchair skills he had from 16 years using a custom manual wheelchair to get around his home, in and out the front door, and in his community. Having back and leg support, he will not feel like he will fall when transferring or sitting or pushing. He can start doing things that he hasn't been able to do for 2 years, including taking the bus, which picks up right outside his house, to get to medical appointments, therapy appointments, laundry, and access other resources available to him, such as meal support, food banks, and community groups and support groups. He is completely isolated and in pain with no hope of having access to independence without a custom wheelchair. He would also have more funds available to eat healthier, get help with cleaning and home care, and needs because he would not have to spend as much on clothes and taxi and Uber rides. He wouldn't have to ask for help anytime he does try to leave the house or have someone drive him somewhere. He used to take his laundry on his lap, the one bus stop away, to wash, dry his own clothes, but has not been able to do that in 3 years. He used to cook for himself, and he looks forward to doing that again. Since his evaluation for this chair, he has started to imagine his future life with hope and excitement. Thank you for your consideration. And that was denied because I'm not a clinician. Okay, so the appeals are powerful when they come from you. Okay, and that is, that's an easy right? And you can write a story for those appeals. So that's important. So unfortunately, because it got denied again, we had to start the process over again. And during that time, he moved out of state. So I am still in touch with him, and I'm trying to get things going there, but he's dealing with the same problems there that he was dealing with here. Okay, so what can we do? What can we do? Okay. So in this situation, yes, he's not safe doing independent transfers. You guys know people do things that they shouldn't do. Okay, like this guy carrying his wheelchair upstairs. Okay, it's gonna happen. Yes, there's clinically necessary and safe, and then there's like real. What is the real world situation that they know that they're dealing with? Okay. Okay, next. Okay, this guy. So this guy, he went to a great inpatient rehab, and he got a great chair, K5, and 4 years after he got the K5, he developed heterotopic ossification. Okay, so what that is, I'm going to just skip to the next slide because it has a picture of it. Basically, his hips became non-reducible. So sitting here, he could sit kind of 90-90, whatever. Now, this is his hip angle, and he cannot sit any other way. Okay, so that's his hip angle. So after 4 years, he was like, well, but insurance only pays for chairs every 5 years, so I can't get a new chair. Okay. Also, he's like, well, I can't sit in any chair. So I can't get it. Even if I got a new chair, I can't sit in any chair. Okay, so that's kind of what happened with him. So an occupational therapist went in, and, well, first of all, a doctor went in. And doctors are great at documenting what is happening. Okay, he is bedbound. Yes, he is. Can we do anything? Can he not be bedbound? Is there any future hope or plan of care to get him not bedbound? Okay, and that's something that most doctors need therapists to kind of prompt that thought. So he was doing home health with occupational therapy and some wound care. And the OT called me and was like, can you do anything with this? Can we do anything here? And so I went in, and
we got him a power wheelchair. I mean, he had a whole setup. He was just in the living room. He had a fridge. He had like a hot plate. Like like around his bed, he was just totally set up. Okay? So we did the evaluation, and it has been 10 years that he has been in that bed. 10 years. This is 14 years post-injury. So when we delivered that chair, I got him in that chair, and we went for a 45-minute walk around his neighborhood. He hasn't been outside in 10 years. 10 years, guys. So anyway, again, success story. This is a success story. It got caught. It got caught by home health, occupational therapy. Yes, good job. What can we do? What can we do? And the 5-year thing really gets stuck in people's head. They really hear that. I encourage you to be careful with that number, because does anyone else in here actually deal with insurance as far as like processing orders? Like not writing for justification, but processing orders with insurance. Does anyone do that? Okay, great. So yes. Yeah. So the thing is that if you don't actually process the order with insurance, I really encourage you to refer people about questions about coverage, to call their insurance, or to talk to someone who does that, okay? Because change of condition, okay, deconditioning, okay, there are ways that we can get modifications, okay? Even if we can't get a new chair, we can do modifications and change a lot about a chair to make it better, okay? And that can be within the 5 years. So just be really careful with that 5-year thing, because it gets stuck in people's brains. Okay, and here we go. This one is the last one. Oh, yeah, so I can't sit in any chair. We got to be creative. Yes, you can. I bet there's an engineer that can do something. You know, if we can send people to the moon, I bet we can get you sitting. Okay? There are ways to do things. Okay, so here's the last one. So, no, second to last one. So this one, so this guy, he's in a rural area, and he's like a welder, and he had a work injury that was complete paraplegia, okay? And work kind of paid for all his care initially, so he did not use insurance for the initial care, okay? So work paid for it. And then he accepted a settlement, which is not a good choice. So he accepted a settlement from work. And you guys know that money ran out pretty quick. So he never got a chair, ever. He's been using a K1 since the day he left inpatient without a cushion, okay? This is 5 years later. The reason that I'm involved 5 years later is because he went and saw his primary care doctor, and his primary care doctor was like, yeah, your wheelchair is 5 years old. We can get you a new one. They set a standard request for a K1 DME chair to replace the one he's using. Because the doctor's like, well, you're alive, and you're here at the office, so I guess this is working, so we'll just replace it, right? That's okay, you know. Not everybody knows all the things, right? That's why we're a team. So I got the order. I'm like, hold up. I'm looking at these notes. I'm like, what? He has contractures. He's got back wounds. He's sleeping in the chair. What is happening? So I go out. We obviously do a whole evaluation. We get him a power wheelchair. It has the 30 degrees of anterior tilt. Jean, you help me with this one. So, I mean, he had wounds on his feet from trying to weld in the K1 chair. Like, again, talk about, like, clinically, you should not be doing that. Okay, but, so what can we do here? So, again, this is a success story. A primary care doctor actually did send an order to a complex rehab provider to help him, although they didn't know what they were doing. Like, they just sent a DME order. It could, if it just was a DME order that went to a standard DME company, it might have just gotten replaced immediately, right? But this was a very custom situation because he had a lot of contractures and stuff too. Luckily, most of them were reducible, so hopefully they won't get worse over time. But yeah, so there we go. So that was another. These are success stories, sadly. Okay, so but I'm very glad that we had it. But his thing, again, the 5-year thing really stuck in his head, too. Okay, that's one reason why he didn't research anything else. He just was like, nope, I can't get anything. Okay, so, and he doesn't have any money for anything special, right? Please don't, just like, so the ATP certification, we are supposed to not ever consider funding when we are making recommendations for equipment. Okay, that's one of our kind of standards that for the credential. And I also encourage you to, regardless of somebody's financial situation, direct them to someone who can either process things or give them resources or talk through that, okay? Because there are options. There are funding options. There are ways to deal with things. There are things that we can do so that people get equipment that keep them alive longer, okay? Last one. Okay, so this one was fun. So this guy, he's been hurt for 35 years, and he just moved here from out of state, up north. And I got an order for just a replacement Roho cushion, and because he's got yet another wound. He has dealt with 3 flap surgeries in like the last 7 years or something. So I'm like, this is why is he getting all these wounds? What is going on? And he's a strong guy, and he's in a manual chair, and I'm like, I wonder if it's time to kind of approach power for the seat functions, because if he's getting wounds that quickly, he might need some of those positioning components to help offload. Like, I wonder what's going on. He's been hurt a long time. How are his shoulders, right? So I'm curious. So I go out, and I'm talking to him, and he's been hurt for 35 years. He's worked with another ATP the whole time. So I go out to do kind of a recon mission, and he has full sensory impairment, so he can't feel anything, right? So he doesn't know what he's sitting on. So I'm sitting there, and we're talking, and I'm like, hey, can you tell me how you interact with your cushion? He was like, what? It's like what do you do? Like, how often do you pump it up? What does that look like? When do you know that it's in the right position? Because I'm looking at it, and it looks a little full, okay? So he's like, oh, okay. Well, I just open the valve, and then I pump it up until it feels like a bike tire, and then I close it, and then I sit on it. I'm like, oh, okay. Has anyone ever really gone over kind of how to maintain the Roho cushion? He was like, yeah, I think they did back when I started using them 8 years ago. Okay, 8 years ago. You've had 3 flap surgeries in 7 years. This is now, I'm extra curious. So I explained the process of the fact that you're not pumping it up to a certain PSI. You are trying to get the air pressure equalized with the air pressure where you are. And you should do that once a week at minimum. Definitely anytime there's a big temperature change, and definitely anytime your car light says that you need to fill your tires. Okay, so or if you're going up a mountain or something like that. Anytime that pressure changes, the cushion's got to be redone. And he had a Quattro, which is where you can kind of lock the air in 4 quadrants instead of the air sloshing all around. And he didn't understand the purpose of that either, so he didn't understand the locking it mechanism, so now he's sitting crooked. So we went over that, and he just looked at me when I was explaining this, and he was like, you saved my butt. And it was hilarious. So we got him sitting on a Roho correctly. But Roho is just the best cushion for wound care, right? A lot of wound care, they'll be like, yeah, we need a Roho cushion. Okay, what if they smoke? What if they have cats? Okay, you got to think about the environments that these are going to be in as well, as far as puncture. Do they have caregivers that can help maintain it? Do they have the hand function to maintain it themselves? Do they understand it? Did they get explained that at delivery when we're explaining 50 other things about the chair? Did it actually resonate? I'm pretty sure most people in this industry are really competent. We're doing our best. But what we say and what people hear and retain are 2 different things. Okay, so we got to be redundant, all that. So anyway, so we did that. But also when I was in his home, I was able to also see his home. And he had a narrow bathroom door, and so he's been doing what I call boot scooting, which is where you get out of your chair and you're on your booty, bouncing around to do the things in the room that your chair can't fit in. Okay, and this is someone with flap surgeries, and I'm like, oh God, and you can't feel anything, so he could jump on anything. So we also got him a cushion that attaches so that he can boot scoot safely. And then I told him about the setback hinges which I'm not going to get into, but it's a way to widen the door without doing construction. And he was like, are you kidding me? I did $6,000 of work on my last house, and all I had to do was replace 3 hinges. So again, the ATP is a resource. We know the technology stuff. Get us involved. We're like the house, residents that go into the home and figure out why the person is sick. You know what I mean? Like, we go in and do the recon mission, and we can report back to you. Okay, so that's that. So, and he ended up getting a bunch of other resources. So those are some case studies. So yeah, making sure, when people are coming in for follow-up, just ask them how they interact with things, right? How often you use in tilt, how often you use in recline. The more you talk about it, the better. The number of times I'm in front of a patient, evaluation, delivery. Okay, I'm in sales. I can't go out and, I do go out and do a lot of training and demos and recons and all that stuff. But I'm not selling anything in those moments. I'm selling safety, and I'm doing what I love, which is advocating and educating the patients that I'm trying to keep safe. Okay, so how is your patient doing, that anchor patient? I'm going to give you a couple minutes to talk to the person next to you. What are some questions? What are you thinking? What are you thinking right now? Just talk to someone next to you about that patient real quick. Okay, so here's kind of the summary, or what are some thoughts or things that we can take away, or things to kind of try to remember. So there are some wonderful systems for getting people mobility devices. There are wonderful systems. When I was in Pittsburgh, I was at the Center for Assistive Technology. Patients would come in for a 4-hour appointment. They would see the doctor, the therapist, the assistive technology, and we would have all the equipment and do trials of everything on site. 4 hours, knocking all the paperwork out. Absolutely everything. Man, that was fun. That was great. Like, not only are we a team, but we're in the same room. Okay, that was just really amazing. Not all clinics function like that. Okay, they all function a little differently. But man, what a great thing to focus on is the clinics. Okay, but it does create kind of this bottleneck a little bit, because not everyone goes to the clinics. A lot of times that's first-time chairs. Okay, people first getting hurt, or people dealing with something that maybe could have been prevented, and maybe we could have been better about maintaining their equipment or modifying their equipment so that they didn't have to come back, okay, to inpatient. Not everyone, but maybe there's a few people there. So what else can we do? Because there are a lot of people out there that are not getting equipment or not understanding how to get equipment. Okay, like the guy who went to, one of the best inpatient rehabs, and then he was in bed for 10 years because he didn't know who to talk to or where to go. When people are stable, they don't have a progressive disease where they're seeing a neurologist or a physical medicine and rehab doctor regularly. If they're just seeing their PCP because their condition is stable, who's looking after their equipment? Okay, a rule that's really interesting with Medicare. So I told you that I can't contact people unless I get a referral. But something else that most people don't know is I can't contact that person if we haven't done equipment for them after 15 months. Okay, so sometimes there's an expectation that the providers will watch over the equipment. Okay, and I agree. I think that should be what it is. But if that person's not actively engaged in getting repairs, so if they get a repair, then I can talk to them for another 15 months. If they get a repair, I can talk to them for another 15 months. Okay, each thing gives me 15 months of access to that patient. Okay, but if they just take equipment and never retain the information on how to advocate for themselves about that equipment, then I lose contact with them. Okay, so what can we do to make sure people are retaining information? What can we do to make sure that you guys are helping ATPs do recon missions to be inquisitive and figure out why problems are happening? Okay, so that's something to think about. So there's a lot of opportunity outside of the great, wonderful clinic settings for seating. Okay, who do you rely on for CRT follow-up? Okay, so we got a list of a bunch of you up here. There's also support groups up there. DME sales folks too. There's counselors. Or is the patient responsible? And do they know how to do it? So, and every team is different. because we all have different skills. We all got here different ways, okay? We all, but just make sure you have an ATP that you trust and you know that you can work with, okay? All the ATPs, again, all of my colleagues, we are all awesome, okay? We love helping patients. We love harnessing ability using equipment, okay? But we all definitely became ATPs in different ways, okay? So find the resource that you're needing for the skills that you need to kind of fill in with your team. And when is CRT in your plan of care? Again, you know, if you only have a patient for 15 days and they're not stable, how do you help bridge the gap? Okay, where's it going? Okay, it might not be you doing it, but are you helping bring in a support person that can make sure that this is going to be thought about at some point? When is it a priority to start that process? So here's kind of an example of all the different interactions someone might have with different care people. But all of those kind of tapered lines, those are the gaps, right? So it's how do we bridge all those gaps? So I have a screening tool that was created by Elise Dew, who's an occupational therapist up in Ohio. And she created this, and you can't read it because it's tiny, but it is a tool that I try to give people who go into homes. Okay, so if you're a nurse, if you're a PTA, again, you don't have to be the person that's going to do the wheelchair evaluation, but are you the person that can catch that we need to do one? Okay, so some of the questions, oh goodness, I can't even read it. I'm going to go over here, out of frame, I know. Does the wheelchair appear to be too narrow or too wide? Does the wheelchair seat appear too long or too short for the patient's legs? Does the patient sit in the wheelchair for prolonged periods of time or unable to tolerate sitting? Does the patient complain of pain while in the chair? Does the patient have difficulty propelling, or does it cause excessive fatigue? Does the patient have a history of an open sore? Is the patient incontinent? Are there anti-sliding devices, interventions to the chair? Do they have pool noodles on their chair? If they do, call an ATP. Okay? We don't want pool noodles. There are better systems out there, I promise. Okay, does the patient lean to the right or left or favor sitting one side? Do they have a rounded upper back or hunchback? Does the patient look like they might slide out of the wheelchair? And then some really big ones are, does the patient have redness or an open sore on their bottom or back? Has the patient fallen from, slid from, or tipped over their current wheelchair? Does the patient not have a wheelchair cushion? Okay, so, or is using blankets or pillows? Okay, so these are pretty basic questions. Is this a screening tool that your team could use for some type of follow-up? Okay, to just make sure that, hey, we need to get this looked at. We need to bring in someone. So here are kind of the big takeaways. So what is your role? If not you, and if not now, then when? Okay, so just keep it in mind. Okay, the responsibility shouldn't fall on you all the time because it depends on when it is. But when is it happening? Who's doing it on your team? Be open to options, even if you don't know they are possible, okay? You guys are experts over here on this, and then there are experts over here on this that can help fill in those gaps and be creative with you. A wheelchair evaluation is about more than just equipment. Stay future focused on autonomy, okay? Give the patient the power, give them a tool. It's not just mobility, it's seating, okay? And always be educating about the process to get and maintain equipment. If you're in front of a patient, please try to bring it up as much as it's relevant to get it in their head, okay? And then it's often not about if, but about when. Okay, so if they're stabilizing and you're hoping they're gonna make a full recovery, I love that hope. I want them to work with therapists and try to make that a reality. But just like someone asked earlier, like when did someone actually tell you what was going on, that you would never walk, right? Like, yeah, so we gotta make sure that we're being realistic, and if we go this way, awesome, let's work to go this way. But if you go this way, then this is that's gonna look like, okay? Because that gives hope too. They're like I always say, I'm in a great industry because I know if I get hurt, I can have a great life. I know what sport I want to do if I get a spinal cord injury or if I get an amputation. You know, I know all the resources. I know the support groups. I know all the best people to talk to. I'm a good person to be friends with because I won't leave you because you're going to have a great life if you get hurt, okay? Because there are a lot of resources out there. And then, who and how do clinicians and therapists get educated? Okay, so this is something that's really important. I'm glad you're here. I also do have you guys, so this is a QR code. I encourage you all to scan it with your phone. Or you can take a picture of it and use that website. But I am here as an ATP today. Okay, I do work for NewMotion, but I have a little side information thing that I do, which is coexist assistive technology. Okay, and yes, I do have a tattoo. And I did put stickers down the aisle so you guys can pass those down, and I have a whole bunch more up here if you want them. But because I go out to people, I don't always have the resources to show people equipment. And so I try to do like 2 to 4 minute videos about a specific thing. Okay, so I have a video about how to maintain a ROHO cushion. And I send that to everybody who is getting a ROHO cushion after evaluation and delivery to try to reinforce. I'm like, watch this 20 times, please. Okay, information about hinges, information about other stuff. Now, I'm doing my best. I do not post that regularly. The pressure is normally when I need it, when I need to show a patient something and I don't have access to it. When I need to show a therapist pressure mapping for tilt, that's another one. So I have one about pressure mapping and using tilt to offload. What a great educational tool for someone to actually see the offloading happening, and now they understand why they should do it, because they can see it. Okay, so you can also send me information, like if you want me to make videos because you're like, I really need a 2-minute video that explains this, that would be amazing. I'll do it. Okay, so that's that. And that is it. Any questions?